for our speakers. Thanks for Dr. Vishali. Today she is our guest speakers, and also this meeting conducted by Middle East Ophthalmology Meeting in collaboration with Ministry of Health in UAE and posterior segment, of Retina Group in Abu Dhabi and North Emirate and Dubai. Today we'll have almost a medical, a posterior segment cases and presentation. We are having also Dr. Patricio and Dr. Ahmed Al-Khashab, Dr. Ahmed Al-Barqi, Dr. Madaf Rao, and we are having also from Novartis as the sponsoring company, Mr. Majid. He will present one topic. Before we start, just I want to remind every participant that they can send their question. There is a button down there, and they can send out their questions. Anyone who wants to participate live and he want to discuss something, also he can just click on share screen, and it's available also there. And then we can open for him the mic, and he can discuss with us whatever he wants according to the presentation and question that he will ask. I would like also to thank all our speakers here today. And the last point, this is this meeting actually is a continuation for the Middle East Ophthalmology Meeting Conference, and anyone who attend this meeting and maybe the next month and the other month and he didn't get the CME of the conference, we will count this for him and we'll send him a complete CME for the conference, which is 15-hour CME. This is the start, and I will start giving actually a short presentation as an introduction for AMD. My presentation, actually, it is just an introduction, and I'm going to highlight certain points in AMD, so we can have another discussions and maybe a presentation by other colleagues. They will elaborate more about AMD, and especially Dr. Vishali, she will elaborate about the fluid and the relation between fluid and AMD and the management related to that. AMD, as you know, is a degenerative retinal disease that can cause central vision loss and lead to a legal blindness. Is the leading cause of permanent, actually we have to remember this, visual impairment, blindness among the elderly, severe vision loss in a people actually above 50 years of age, mostly in the Western world, where they are having more than 50 countries, developed countries, and they are having a high incidence of AMD. Age-related macular degeneration remains a significant public health problem. AMD accounts for around 9% of all blindness worldwide, increasing prevalence as a consequence of exponential aging population. Global burden, this is very important, estimated to increase from almost 200 million in 2020 to about 300 million by 2040. Estimated also prevalence in USA adult with advanced AMD, it's by age or gender. If you can see here, the number increase or the percentage of the people they are having age-related macular degeneration is related to the age. And you can see here, those they are having from 40 to 90, they are having less, then it will be increased between 50 to 50. And it will be very, very high in whenever the people above 80 years of age, which will reach about 1 million of populations in this category of age. As you know, female, they are more common than a male, and this is how is it showing here. It's all men about 0.57 of the million, while a woman it will be more higher, 1.17, and the total it will be, as one you can see here, 1.75. AMD risk, there is a risk factor for AMD. We have to take this in consideration, and that's why it is a difficult disease to treat, and two tackles. There is non-modifiable, which is genetic or gender, female or age, and we cannot play on this one, except maybe genetic future. We hope that there will be a progress, something related to the genetic that can treat this disease. Modifiable, which is diet, low antioxidant intake. So if we are encouraging our patient to take a diet or that's having antioxidant, maybe it will can help. Also cigarette smoking, if you can stop cigarette smoking, if you can decrease the ask the people also to have less, more physical activity, and so less obesity. AMD decrease quality of life. This is the most important things that we know. That AMD, it will increase the incidence of depression of the patients, increase the mortality risk, also great need for assistance, because especially in this kind of or category of patients, they are having, they need an assistance in comparison to those not having an AMD in the same age. AMD symptoms, this one I think most of you they know: decreased vision, distortion, there will be central or paracentral scotoma, decreased contrast sensitivity. And for evolution of the therapy for new vascular AMD, as all of you we know that we are having before, just in early 1980s, we are only having a laser as for laser photocoagulation to treat AMD. Then we are having a photodynamic therapy, and then we have submacular surgery, and all this one they are only halt progression. That's by these methods of treatment we are usually only trying to halt the progression even. But whenever the era of the anti-VEGF therapy comes, this one from 2006, it will improve the vision. We are not only trying to halt the progressions and prevent deterioration, no, but here we are trying also to improve the vision. The incidence of blindness has been reduced since the advent of anti-VEGF therapy, and it is showing here in this paragraph that it's decreasing accordingly, and the percentage decreased. Factor influencing the optimal visual outcomes in a patient with new vascular AMD, we have to treat early, and this is very, very important. So early diagnosis and treatment ensure improved visual outcome. Sustain also treatment, sustain therapy can maintain early visual gains in the long term. Treatment sufficient injection frequency result in a better visual outcome. This is very important factors that we take care in our or keep in our minds when we are treating cases of neovascular AMD. Treat early, as we mentioned. Final visual outcome are better in a patient who receive early diagnosis and early anti-VEGF therapy, and it can be shown here in Luminous study. Treat sufficiently. Real-world evidence also highlight the relationship between injection frequency and visual acuity gains. As the injection increase, is one which is here shown, more than 5.1 injection required to maintain baseline vision in the first year of treatment. More than 7.9 injection required to improve. So if we want only less, as we give the patient less injection, then we are just only maintaining if we can maintain the visual acuity. But if we are giving the efficient and the real number they need for the patient, especially in the first year and as early as we diagnose, then we can have an improve of vision from the baseline. Maybe we can reach to a more than 15 letter in a first year of treatments. Also, sustained treatment is adequate and continue anti-VEGF therapy maintain long-term vision in the real-world evidence studies. Physician prospective treatment burden remains as a major need. This one unmet needs. This one it's shown here is reduced treatment burden. It will be, if we can do it, it will be more better, but it's still physician and unmet need. It's still a major problem for the treatment of neovascular AMD. Also, the real world evidence show that over 70% of patients are untreated in the first year, undertreated in the first year of therapy. That's what is shown here everywhere. That's we are giving less, and that's why we are not getting exactly the improvement that we are willing when we are treating the patients. Also here, the real world evidence shows that undertreatment is associated final visual acuity with worsening visual acuity in a final across all the years. If we start with in a year, it will be 23, then 39, then it will be decreasing because as visual acuity is worsening because of we are not giving the correct maybe number of injection for our patients. So in summary, increasing prevalence of AMD contribute to vision impairment and blindness. Multiple factors are implicated in conferring increased risk of development and progression of AMD, including demographic, genetic, and behavioral. Decrease in quality of life with AMD highlights need for more effective treatment strategies. Also, in summary, anti-VEGF therapies have proven efficacy for the treatment of AMD. However, real-world evidence shows suboptimal visual outcomes in a patient, often due to undertreatment. AMD management is a significant burden on a patient and healthcare providers, and poses a major challenge for sufficient and sustainable treatment. New therapeutic agents with greater durability that would allow adequate long-term control of the disease are warranted and can potentially address the unmet need in neovascular AMD. So the take-home message from this one, that age-related macular degeneration is a debilitating disease, and we should treat it while we still can. And thank you. If there is any questions.
Thanks a lot.
Or any comments? Dr. Ahmed, Patricio, Dr. Vishali. So if nobody will ask me, I will ask, because this may be okay. So do you think it is really we are treating the patient, I mean, correctly, and we treat it whenever we are detecting, or the real data, real data is really, you can say, showing what we are doing? Even let us talk about ourselves that we are here now. How do you feel? Because most of them, they are telling we are not giving more than 4 injection or for something in the first year as an average.
Usually we tend to be more aggressive in choroidal neovascular membrane rather than in diabetic macular edema. So I feel maybe this is because of the infrequency of the problem here in Middle East and UAE. So we tend to be more aggressive in such patients, but I feel this is an under treatment in comparison to DME. Patricio, your
yes.
Yeah, well, we have one thing in this country first. The prevalence of AMD is quite low because of the population profile. As you know, most of the population, specifically in Dubai and Abu Dhabi, are expats, and by the age of 60 they go home. So we don't see as many cases as we see in Europe or as they see in the States. The other thing is the patients, they come, but once they get clear of the sub-retinal fluid or intra-retinal fluid, the vision improves, they disappear. I will show you one case where we lost the follow-up of the patient for many months, and they come back thinking that every time they come back, they can get the same results as the first time. So one of the things is that you actually have to spend some time explaining to these patients that it is going to be a chronic disease for life, for all the remaining of the life of these patients, and that they can be in treatment for many, many years to come. We try to give them in our hands roughly 7 injections a year on a treat and extend, but as I said, I mean, many of them disappear.
Okay, Madaf.
Yeah. So as you showed in one of your slides, the clinical trial versus the real world data, the clinical trial definitely showed the number of injections to be higher in the first year and the subsequent 4 years as well. Whereas in the real world, as Dr. Patricio said, the patients hardly take around 5 or 6 injections in the first year. This is it's common in all throughout. I mean, whether it's US, Europe, or probably we don't have a big data in UAE, but I would also probably say yes, we get less, they tend to lose a follow-up in the of the
Do you
cup
think
of
because
injection.
of the follow-up, or because maybe that means we are using treat and extend, or you are increasing up to, for example, nowadays, instead of you can Q12, Q9, this is the strategy, Q16.
Well, now coming back to diabetes and exudative AMD, they are completely different diseases.
Yeah, we are
know
talking
that,
AMD.
Yeah, so diabetic macular edema, we know that you hit hard. The first year probably is more injections. Second year, we have a defined number of injections, and third year, it becomes even less. And subsequently, they require very less number of injections, unlike the exudative AMDs, where you probably have to go on for many more years. Now, this is where, I mean, they do probably better with a couple of injections, and they think that they have done well. The visual acuity is stable, and they just won't follow up regularly in clinics.
Ahmed,
yeah, I think also I agree with all my colleagues that I think the main issue here, the main problem you have is the undertreatment. I believe this is common. I've seen undertreatment because, as Patricia said, the incidence of the disease compared to DME is less. And also what I have seen that in AMD, also the real world data rarely mirroring the clinical trial, because the clinical trial, the trial is well designed, and the follow-up is very, very maintained. But in our practice also, we face the problem, as Patricia said, and Rao also, the non-compliant patient disappear suddenly for many reasons, not only that he improved, but sometimes you have patients from far. But so we have many factors, and I believe we need to do a lot of effort on patient education. Since the disease is not common like DME, I think we should do some awareness for the patient about the severity of the disease, and he might lose vision if he didn't came to regular follow-up and injection.
Dr. Vishali, if you have any comments.
Yes, I think the world of trial and the real world are very different. Like, I have patients in the trial where one eye is in trial and the other eye is the real world, because there the patient has to buy it for himself. It doesn't work the same. I mean, there are affordability issues when the OCT is showing a thickness of 240 micron and he is seeing well, the patient doesn't want injection. Whereas when he's in the trial, even if it is 250 micron or 300 micron, if the protocol says you got to inject, you got to inject. So I think we were never able to replicate trials into the clinical practice, because real world is very different from that world of the trials. So that is why trials remain on one side and real world remains the other. In India, we are kind of forced to practice PRN because most of our patients do not have insurance. So even treat and extend doesn't work.
Thank you very much, Doctor. Maybe I have another question, but we can keep it till the end. Now we can have Dr. Vishali Gupta. She will talk about relevance of fluid in neovascular AMD. Dr. Vishali, please.
Thank you. Thank you, Professor Amri, and I'm really, really grateful to Middle Eastern Ophthalmological Society for always inviting me, and it's always a pleasure to interact with you all.
It's our pleasure, actually, Dr. Vishali. Thank you.
Thank you. So I'll be talking about the fluid. So where does this concept of fluid come from? Now, when we were monitoring the anatomical outcomes right from the beginning of AMD trials, there were different parameters we were looking at. On OCT, there was fluid, which was in terms of thickness, and then there was SHREM, and of course, hemorrhage, intra-retinal or subretinal, which was not always on OCT, but mostly we were looking at it clinically. And before OCT era, we were actually looking at the angiography to look for the leakage and activity. And some of you young ones won't even know that we actually used to repeat angiography to see whether the patient is responding or not responding. So here are the different OCT biomarkers which we have been seeing from time to time. So what are these? So what are these? We look for the intra-retinal fluid, we look for subretinal fluid, we look for sub-RPE fluid, sometimes subretinal hemorrhage, and this hyperreflective here, this is SHREM, or the subretinal hyperreflective material. So where did this knowledge of fluid come from? Starting from trial in the CAT and going up to trial after trial, most of the trials felt that if there was fluid on OCT, you will inject. You just listen right now that many a times we are not really following a true protocol of injecting, but anytime our patient is on PRN, or even if it on treat and extend, the moment you see the appearance of fluid on OCT, you are obliged to treat. And that is because all the trials have shown us that if you see fluid on OCT, please go ahead and treat. Not only the trials, but even the societies, if you see the recommendations by Retina, by American Academy, they all tell you that if you see the fluid on OCT, you should be treating. Now, what is the relevance of the fluid? Fluid helps in making the diagnosis, time to treatment, treatment interval, and visual outcome. What exactly is the fluid? So we have three distinct types of fluid. When there is a membrane, the first fluid to appear is underneath the RPE, which is here, this fluid, and this is sub-RPE fluid. This goes on to then active disease, which is subretinal fluid here, and then there can be intra-retinal fluid. So the fluids are in different categories. So in the sequence of the events, all retinal fluid, whether you see subretinal, intra-retinal, or sub-RPE, they all indicate that the disease is active. Two trials, Saylor and Harbour, they were the first ones to comment on the fluid. Besides the CAT and all, they said that if you detect the retinal fluid on spectral domain OCT, it means you have to treat it, which results in the better outcome. So detection of the fluid was the key. But as I mentioned, the fluid could be either intraretinal, subretinal, or sub-RPE. The important question is, should these three compartments be treated differently? So let's start with intraretinal fluid. Intraretinal fluid is what you see here is this cyst within the retina. Now this is the bad guy of all the three types of the fluid. This is the real bad guy. Because if you see these cysts at baseline, it means the visual outcome is going to be poorer. And if you are treating, but these cysts are either persisting or they are reappearing after injection, that again indicates a poorer visual outcome. So if we go to view 1 or view 2 study post hoc analysis, they showed that presence of intraretinal fluid at the baseline means it's going to have a poorer outcome. There was also secondary analysis of the CAT study which said that if intraretinal fluid was persistent, it means the visual outcome is going to be poor during anti-VEGF treatment. And they also said that the adverse effect of intraretinal fluid worsened over time And it was present at all time points, means that inclusion at follow-up, intra-retinal fluid would be associated with the poorer visual outcome. Then post hoc analysis of Excite that showed that if there was new intraretinal cyst early after the loading, it means the visual acuity in this patient is not going to be very good. So intraretinal fluid at any point of time, poorer outcome. Now we come to the subretinal fluid, something like this. Contrary to intraretinal fluid, subretinal fluid is actually a good guy because many studies showed that if you have subretinal fluid at the baseline and you don't have much of intraretinal fluid, it actually means there would be a good visual outcome. And very interestingly, many data also suggested that even if you let little bit of subretinal fluid persist, this is actually good for the maintenance of visual acuity. So if you just have the subretinal fluid, you don't have to make your retina bone dry. You can tolerate a bit amount of subretinal fluid. So this is a secondary analysis of VIEW study, which studied the effect of baseline subretinal fluid on visual acuity. And this study determined that the presence of subretinal fluid at baseline did not greatly affect the initial visual acuity. And if you are treating it, the relative outcome and the visual outcome is good with anti-VEGF therapy. Secondary analysis of CAT study 2 showed that even if SRF persisted after treatment, it did not adversely affect the visual outcome during anti-VEGF treatment. So there was ancillary study of Excite, which mentioned that repeated recurrence of SRF was not as good as previous studies mentioned, though at baseline it is good. If it is persistent, it might be fine. But if it is reoccurring, then even SRF is not good and it may lead to poor visual outcomes. So there was a very interesting study, fluid study. The only aim of this study was to see whether some degree of SRF could be tolerated and could you have a little bit of SRF without making retina too dry. So what they did very interestingly divided it into 2 groups, intense group and relaxed group. So intense group was where they made it like after the loading dose, they gave it monthly till there was a complete resolution of SRF and IRF. Whereas in the relaxed arm, if the SRF was less than 200 micron, they did not really treat it. And they compared both the groups. They found there was no significant difference between the intensive group and the relaxed group for a mean change in the best corrected visual acuity, which means that even if you have a little bit of SRF left, as long as it is less than 200 micron, probably it's not going to affect your visual acuity adversely. Now, this knowledge will come into play when we are talking of the real world, where you have to decide, patients are old, they have to depend on others for bringing them, and there are financial issues. So little bit of SRF, less than 200 micron. If you want to avoid, you have the studies which can support you not to inject. This is just to show you a clinical example of a patient with AMD. And this is classical subretinal fluid, no intraretinal spaces. Now, when you see a patient like this, you know the prognosis is going to be good. And here you give 3 injections, it is sorted. And even after 1 year, the visual acuity is maintained and the fluid has not come back. But these patients are not too many. So as I mentioned, the fluid study took the 2 arms, intensive arms and relaxed arms. So now comes the catch. What they found that although there was no significant difference in the visual acuity, but if you allow the subretinal fluid to persist for very long, quite a few of them develop intra-retinal fluid. And intra-retinal, we all know, is a bad guy all along. So even the subretinal fluid, for some amount you can tolerate, but don't keep it for too long chronically, because even this has a propensity to develop intraretinal fluid. Now we come to the third fluid, which we honestly don't talk much about, that is the sub-RPE fluid. We don't talk about it, and there are not many studies who have actually investigated the importance of subretinal fluid. However, it's very important to know about this fluid because this is the site of action. This is where your whole membrane is. So this is the fluid where first changes of activity might come if you are monitoring your patients very closely. So post hoc analysis, if we see view 1 and view 2, they actually said if there was PD at baseline, there was no impact on the visual acuity and no impact on the outcomes with anti-VEGF treatment. If we look at secondary analysis of CAT study, they say sub-RP fluid did not affect the visual acuity during anti-VEGF treatment. However, when we go to the real-world studies, retrospective studies showed that PEDs have been associated with poor outcome in a real-world setting. So, early changes in the sub-RPE space actually might predict that there is going to be recurrence of the neovascular AMD. And I'm going to show you an example of this patient of AMD. If we see, he just had PED, and you can see some fluid beneath the PED. He received injections, aflibercept, and you can see PED kind of, the height of the PED reduced, and patient was responding. So he did not want any more injections. And we have not seen him, but what I wanted to show you is if you are actually treating the sub-RPE fluid, then you've got to measure the height of the PED. And of course, these days we all combine it with OCT angiography to look for the neovascular network. However, you don't let this ignore, and this is the example of a patient where the things can, to show you how important sub-RPE fluid could be. This is a patient with a membrane, and we see the membrane on ICG, fluorescein, and this is the OCT, which shows subretinal fluid and looks like a good prognosis. Vision is actually 6/9 at this point of time. Receives 3 intravitreal injection. You can see the subretinal fluid is gone. But if you see here, there is this streak of the fluid, which is now the sub-RPE fluid. However, the vision was good, 20/20, and this fluid was there, which was not affecting his vision, and the patient did not want injection. He was lost to follow. When he comes back to us 14 months later, this streak of the fluid now, there is subretinal fluid, there is intraretinal fluid, there are all the 3 fluids right now present, and even after injection, the response is not so good because he needs lots of injections probably now to manage it. So this is the fluid story that continues to evolve, but in the moral of the story, any fluid anywhere indicates active disease. Fluid resolution does correlate to visual benefit. The magnitude may vary. Subretinal would respond more, sub-RPE would respond, intraretinal may not, but wherever the fluid is, you've got to treat. The more stable CST means, and if you have the more stable central thickness, it means better disease control and better visual outcomes. So in short, don't ignore fluid wherever it is, and it's important to treat it, even though you may not be treating the patient on regular protocol. But the moment you see fluid, you got to treat it. Thank you.
Thank you very much, Dr. Vishali, for very excellent presentations and highlighting about all these points, explaining in a very nice way. If there is any question from here, any colleagues to Dr. Vishali, Dr. Ahmad, Dr. Madaf, Patricio, Ahmad.
Yeah, yes.
Okay.
Ma'am, yeah. So when we talk about the subretinal fluid, when we extrapolate the same from other disease conditions, like it could be a diabetic macular edema, CRVOs, or even in a chronic CSR, we don't accept a subretinal fluid for a very long time. We say it results in a photoreceptor damage, as well as it can cause a secondary RP damage, so RP atrophies. So why is that? I mean, I know you presented very well. Why is that we are tolerant to a subretinal fluid in exudative AMD? Is it a completely different disease?
A chronic CSE is a different disease because the choriocapillaries are getting ischemic there. You know, the chronic CSE is a part of pachychoroid. So I will say chronic is different, but when we come to diabetic macular edema, and this is more fields like Adnan is supporting it, they always say that little bit of fluid is good because your hard exudates kind of keep floating in it. And the moment you kind of make it bone dry, the whole thing comes into the foveal center. That is one. And second is they say it's good for the photoreceptor if you don't make it too dry. And, you know, but these are all concepts. They are, nothing has been proven. And even in the trials, when they have said that little bit of SRF you can tolerate, it doesn't affect the visual acuity. But if you go into very long term, that same subretinal fluid also produces intra-retinal fluid, and then it becomes a bad person, you know. So I would clinically, practically putting it, I will just say that if you are seeing little bit of subretinal fluid, and your patient doesn't want injection, probably there is no need to panic. You can still keep him under close observation and can increase the interval a bit. But it really doesn't mean that we can tolerate it for very long. Like I know from my VKH and sympathetic ophthalmia patients, because I'm a uveitis person too. I mean, I see the fluid and I want to give them IV methylprednisolone because I know the sooner it goes back, the quicker the recovery is, you know, so that is all our knowledge. So but this is what the trials say. Honestly, though I'm running 9 trials, I'm not a big fan of trials. The real world is very different from the trial world. So I mean, I see like our clinic, Dr. Madhav, our clinic, we see around 400 to 500 retina patients every day, at least in pre-COVID era. And sometimes for 2-3 weeks and sometimes for a month, we don't find a single patient who fits into the trial, you know. So when the result comes, we want to put the result of that single patient, which took us a month to be eligible for the trial, to the remaining 2,000 patients, which we see in a week. How is it that possible? You know, so I never follow the, I do the trials, but I'm not a big fan of extrapolating them to real world.
Continuing with the same question, ma'am, I just have a, you know, in clinical practice, if you see a fluid and if you measure the fluid as 50 microns, or in the next patient as 100 microns and the third as 200, where do you treat them?
I would
like
look at
each one of them have shown is there is a Altair.
As my clinical experience, Dr. Madhav, I will do the autofluorescence. I would see if there is associated atrophy of the RPE or not. If the area of the RPE atrophy over a period of injections is increasing, I would go slow. I would not be pushing in more and more fluid because we do know somewhere that too much anti-VEGF themselves can cause RPE atrophy besides drying the fluid. However, if the patient is fine on autofluorescence and there is no progression in the atrophy of this, I would be happy injecting with any amount of fluid. So I would rather customize depending on the patient's profile, patient's other functions. And not
thank you, Madaf. Ahmed, if you have questions, Barqi.
Yeah. Thank you so much for excellent presentation actually about the fluid. And I'm going to go through the same point that we're discussing, which is because it's a debatable point, and I believe some people still doing that and some people does not like, which is tolerating fluid. Because I agree with you, Dr. Jabta, that I am not a big fan of tolerating fluid because, as you mentioned in your presentation, any fluid, it's a reflect on a pathology. And if you want to tolerate a fluid in a case of AMD, regarding the sub-retinal fluids, and you said that it's no effect on the visual function and the visual acuity, but I do believe that this kind of fluid persistent there for a long time, it might affect the vision, because in this study, a fluid study, the study was only for 24 months, but we don't know what is the dimension, what is the flow if they were more than. And those patients, usually we treat them or follow up for more than 5 or 6 years. Another important point that if you decide to tolerate fluids, I believe this patient should be continually follow up. We cannot try treat and extend with this patient because sometimes the fluid go up again and recurrent again. So this fluctuation, we all know from the trial that the fluctuation will have a permanent visual loss. And another last point is nobody can tell us now what is the exact amount of fluid can be tolerated, because in other trial recently published using the artificial intelligence to evaluate the fluid of the amount of fluid and the effect of vision, they found that 100 nanoliter of fluid, 100 nanoliter of fluid have impact on visual outcome. So this gives us the idea of Porter. So it should be taken, relaxed, because it's not like the clinical trial. We have a continuous follow-up, but in real life, we have different situations. So I think it should be considered when you decide to tolerate fluid. Shouldn't be taken. It should be considered. More and more. Not like I can tolerate some fluid and leave it. And again, what involved the patient have a thin retina, because in the fluid trial, they tolerate less than 200 micron. What about this patient originally thin? The retina is thin, so 200 micron in this patient will not be the same for a normal retina or thickness with what we have seen in the trial. So I think this should be considered, not take it easily, or lightly. That's what I believe.
Yeah.
Thank you, Ahmed. Dr. Patricio. Yeah.
I have the idea that the membrane is there doing something for the RPE. So the fluid is just a reflection on the activity of the membrane. And as long as the membrane is there supporting the RPE, there will be no RPE atrophy. There will be no geographic atrophy at all. We have to be cautious. We still don't know what's the role, of course, of the fluid. But let's say we can divide the choroidal neovascularization into the good ones and the bad ones, as Dr. Vishali said before. And some of them definitely are supporting the RPE and giving maybe a long-standing better visual acuity than if you just dry them up very, very quickly and the RPE breaks down. I don't know what's your thoughts about this, but that's what I'm thinking about some of the membranes.
Yeah, Dr. Vishali, your comment?
No, I agree. We do not understand, because he's right. In the area where there is a membrane, there is no RPE atrophy. In the area where the membrane is scarring, there is RPE atrophy. And then on top of that, we now have this trial showing us that anti-VEGF drugs themselves can cause RPE atrophy. So we honestly do not understand whether when we are told that it has to be bone dry, is it pharmaceutically driven? I'm sorry to say, but is it industry-driven initiative that you just make it dry? So I would look at each patient differently. I agree with Dr. Patricio. We do not, these are very basic science questions. We are clinicians, but we really do not understand the fine balance. And every trial shows different results. So every new days, there is a new trial which shows something different, and then we are all confused. But in the end of the day, Dr. Patricio, it is you and your patient. And your sixth sense tells you what to do for that patient.
Definitely. Thank you, Dr. Avishali.
Dr. Ahmed Khashab, you have any comments or questions? Okay, thank you very much, Dr. Vishali.
Thank you.
Yeah, Ahmed. So thank you very much.
I agree with all what is said already.
Thank you very much. So maybe we'll have a question at the end. So if there is any questions, now we can have my dear friend, Dr. Patricio, and he will present one case and we can discuss this case. Dr. Patricio.
Yeah, thank you, Dr. Alhambri, for your kind invitation. Always a pleasure to be with you and all the panel that you brought today to our meeting. So today I'm going to present, as usual, a medical retina case that I just put the name of DME by mistake. This is a patient that presented to us before 2017, but in 2017 we changed our medical record system to electronic one. So now it's very difficult to get the old paper files back into your clinic. It can take maybe 24, 48 hours. So let's say the patient is coming in 2017. That's the first record I have of him in our EPIC system. This is a 59 years old male patient with diabetes type 2 for the last 10 years on oral medication. And the last HbA1c was 6.7%, which is slightly higher than normal, but it's not so bad. When you see patients with 13, 16%, you think that these people coming with 6.7%, they're very good and they're very tight on their glucose levels. He was also a known, well-controlled hypertensive person, and in the review of systems, there were no other significant pathologies. On examination, on presentation in September 2017, the best correct visual acuity was 1 in both eyes. He was hyperopic, +2 diopter sphere in both eyes. He has a mild bilateral nuclear sclerosis, normal IOP, a very minor, very moderate NPDR in both eyes, and no center-involved DME in both eyes. And he also had, probably we did for him, I'm not sure, because as I said, I didn't review the paper file, a few focal laser scars in both temporal maculae. So in this visit, as I said, the vision, the presenting vision was 1 in both eyes. We did the OCT for the right eye, and we can see here maybe a few exudates here with a laser pointer. Yeah, maybe here as well. But there is no fluid, there is nothing. Maybe some faint ellipsoid zone here, some RPE changes, definitely nothing major. Now we go for the left eye. And again, we see a few hard exudates here, maybe something here as well. At the red free, we see an area of, let's say, RPE changes here, but nothing very striking. And the OCT shows no intra-retinal fluid, not subretinal fluid, nothing, no edema. But wait a second, there is something here. There is something like a half flying saucer image. We can see that the outer nuclear layer is thinner and disappears here. And the outer plexiform the same and disappears here. And the ellipsoid zone disappears here. Well, he has no fluid, he's a diabetic, we don't care. Very minor, non-center involved DME. So we told the patient come back in 3 months. He disappeared for 6 months. When he comes back, still visual acuity was fortunately 100% in both eyes. Now the OCT of the left shows no fluid, maybe a little bit more of increased thickness, a higher thickness and a more large area, and the same RPE changes here. But again, and the same outer layers atrophy here, no fluid. So come back later, maybe in 3-4 months again. But the patient was lost for follow-up for 16 months. Fortunately, the visual acuity was 1 again in August 2019. There was no fluid. The area was a little bit maybe bigger. And there is definitely exudation here. You can see the white hard exudates at the red-free picture. But again, there was no center involved as DME, so we applied protocol S and come back in 4 months. So again, the patient comes back in 6 months instead of 3-4 months. Visual acuity was 1. I saw the patient myself, and this is the appearance, the color picture. We can see that definitely the patient has DME here, here, some hard exudates here. Is this the macula? Maybe it's not the macula. And definitely hard exudates here. A few microaneurysm and a small inter-retinal hemorrhage, but there is an area of a faint subretinal hemorrhage here. I don't know if you can see it on your screen, but it is here, very faint, very faint. So I requested an OCT as usual, and we can see that the area is getting bigger. Now the center is thicker than 300 microns, and now we get subretinal fluid. So you start thinking, oh my God, more than 300 subretinal fluid, center involved, DME, so I have to treat this patient. So I requested a progression chart, and we can see here that from 2017, 2018, wow, this is a big difference, right? But wait, it's not the same patient. This patient has capping, this patient has no capping. This patient has an L-shaped vein here, and my patient does not have the L-shaped vein here. So this is a different patient, but he was lucky to get the OCT with the medical record of the same patient. So beware of this as well. In any case, we see that from the beginning, in September to April 2018, there is practically no difference. Then a few months later in 2018, the area is getting thicker, bigger. And finally, in February 2020, the area is center involving the macula. And so I was questioning myself, is there anything more than DME here? Because the other eye was fine, nothing here. This DME was highly progressive. The progression was very, very fast. So I requested an OCTA. And you can see here at the OCTA that we have a choroidal neovascular membrane superior to fovea. I'm going to show you now the flow of the membrane. You see that there is high flow here, and you can see that there is both subretinal and sub-RPE fluid with flow inside of the RPE detachment here. So what is the plan? Well, we usually go for a loading dose of anti-VEGF, 3 injections, and reevaluate after the last injection. If there is good response, we put our patients on treat and extend, usually by 8 weeks. If there is poor or no response, we switch the anti-VEGFs. But then COVID-19 came, and we were only able to give this patient 2 injections. The patient was again lost for follow-up for 6 months and came back in September this year. Corrected visual acuity was 1. As you can see, the subretinal fluid has disappeared. The membrane is slightly smaller and has less flow. But there is still some subretinal fluid at the level of the choroidal neovascular membrane. Also, the exudates at the other parts here and here, you remember the patient had disappeared, and also the exudation here is a little bit less than before. So what is the plan? Well, back to square one. Loading doses of 3 anti-VEGF. If good response, treat and extend. If good response or no response, switch anti-VEGF. And my conclusions are that not all DME look like are really DME, that it is worth it to rule out CNV with an OCTA in people over 50 years of age or with a typical DME. And you can say, what is a typical DME for you? Okay, for me, a typical DME is the DME with progressive, but with no visible microaneurysms and increasing amount of exudates. The one with high asymmetry between eyes or the presence of a large interretinal or subretinal hemorrhage, a rapid progression or a grayish retinal area around the exudates or below the exudates. And thank you so much, everyone.
Thank you very much, Patricio.
Thank you.
Excellent
Thanks a
case
lot.
presentations. Okay, any question to Dr. Patricio?
Yeah, okay.
Okay,
So,
we can take Ahmed Khashab now.
Patricio, perfect presentation. Actually, in this case specifically, so we have seen that there was some element of progression of the hard exudates over years. In your diagnosis, this was initially choroidal neovascular membrane since the start? And if so, in such case, and with this poor progression of the choroidal neovascular membrane, and what we have seen after the disappearance of the patient after 6 months, why would you consider giving anti-VEGF again? Why not to keep him monitoring, even with this very minimal fluid around the membrane, not in the macula, not in the fovea? So why not to keep monitoring the patient even after a couple of months more and see whether it progressed or not?
Sure.
So it is a double question.
First, the patient is a non-compliant patient, so you cannot trust the patient is going to come. So you inject him as soon as you can inject him and see what happens. Maybe he will come back in 1 year. So for 3 times, he never came back on the scheduled appointment. So you cannot trust the patient. You have to be more aggressive with them. It's same as when you see, for example, a severe non-proliferative diabetic retinopathy in a patient that comes to you every year, and you said, okay, I will do for you PRP today, because the patient is going to disappear. There is no real indication for this if you go by the book. But you know that the patient, the time when he comes back, he or she comes back, is going to be a PDR. In this case, I apply this rule for this patient. I agree, and we were talking about the subretinal fluid and the like. I have no rush. If this patient comes to me for a PRN every month or every month and a half, I wouldn't mind to inject him on demand and keep this subretinal fluid, which is quite far away, and the membrane is quite far away from the fovea. But we see the progression. I mean, the progression is clear. The other thing is a good question. I cannot answer the question if the membrane was there from the beginning. I think the membrane was there from the beginning because there is an RP changes at the red free, but I don't have any OCTA, I don't have any fluorescein angiography because this patient was really overlooked. You have 10 seconds to have a look at the printout. You see, okay, there is no edema, come back in 3 months, next patient. You know how this goes. You don't scroll up and down the screen to see if there is something like double layer sign, if there is some subretinal fluid, because as long as the central subretinal field is free, you apply protocol S and come back in 3-4 months. I think that is what we are wrongly doing, but that's what we are doing.
Okay, Madaf, please. If we can have a very short answer, please, so we can be in a time. Yes, please go ahead, Dr. Madaf.
Thank you, Dr. Patricio, for the nice case. So my question goes back to the initial, evaluation. When we saw his OCT, there was outer retinal layer loss with a, ellipsoid zone was disturbed. Is it primarily because of, was there any inflammatory process? We have Dr. Vaishali here. Because it's not looking, it's not a classic case of exudative AMD, age-related macular degeneration. So there is something else going on, and which probably would have caused a secondary membrane, and subsequently he would have exudated more, and he would have seen over a period of time a larger subretinal fluid and exudation.
Yeah, I agree with you.
What was the reason for that? Yeah.
I agree with you. When you see this outer layers atrophy, you have to think maybe of cancer-associated retinopathy or non-neoplastic associated retinopathy. But I think that this is a case, it's usually bilateral. This is a unilateral case, only in one area. I review the OCTs. There is only one area, the papillomacular bundle in the left eye. And I didn't check because I prepared the case for this presentation, but I think this case could be trauma-related. There is no signs of inflammation whatsoever, and the patient is fine. But I agree with you completely.
Your patient hypertensive also?
Yes, the patient is a non-hypertensive patient, yes.
Because the first OCT you showed, he had this hyperreflectivity in the middle layers, something called PAM, which is indicative of occlusive. And when I looked at the OCT, I thought, oh, this could be a small macular BRVO, which was showing those exudates and all. but then you showed C and VM towards the end. So I was waiting for macular deerview, to be very honest with you.
Yeah, definitely. The thing is that the inner layers are completely normal. It's
Yeah,
just
but that middle layer, that hyper-reflective band was there, you know. That was bothering me.
But yeah, it's a possibility. Yeah.
So have you done an angiogram even after diagnosing a case of CNV?
Not yet. I will catch him for the next visit, and I will update in another presentation.
Yes, very nice. So you are booking now another presentation.
Yeah, I
Okay,
have one
Ahmed.
comment for Dr. But a very nice case, Dr. Badji, because I think this is raised the concept, you know, after the era of OCTA. Now we have what we call subcategories called silent CNV, which you diagnose it accidentally when you are doing OCTA for both eyes. You find one eye is diagnosed as CNV, and you find in the other eye what you've described in this case. You have a well-described membrane, but it's not leaking, not active, nothing. So my question, it's not for you, for all the panelists. If you have let's imagine a different scenario that in your case. For example, if you have a single-eyed patient and he lost the first eye from complication of AMD, scarring and this, and doing OCTA for the normal eyes, which is 6/6, and you find exactly the typical silent CNV. So how do you deal with this patient? Do you treat or do you wait until the fluid came and then start to treat?
No,
for
because
everyone, if you want to share, yeah,
because I believe
this
that
question needs to come to my mind, yeah.
This membrane, which is not active, is one of the good membranes and can be supporting the RPE and can be giving the patient many years of sight. I have been following in my hands patients for 3 years with no activity and good visual acuity. And I remember Professor Makti from Egypt. He has been following one case for 5 years with no sub-retinal or intra-retinal fluid and good visual acuity. So I wouldn't rush to treat this, because what are you going to treat? You kill the membrane,
Exactly.
you kill the RPE.
Yeah.
Many times, if the membranes are not leaking, but the patient sometimes complains of metamorphopsia.
Yeah.
Those are the patients who really get help by treating. And nowadays, with AI algorithms, the area of the membrane is also being mapped. And if you see the hairpin loops at the edges and the area increasing and patient becoming symptomatic, then you can treat. But by and large, subclinical membrane accidentally discovered, you just keep it under observation, not treat.
Thank you very much for all of you. We can now proceed, and we will go now to dear Dr. Ahmed Al-Khashab for a case presentation.
Thanks a lot. Thank you, dear Mohammed, and thanks all for having me. It is very nice discussion. So I will rush into a couple of cases. This one is a medical case. He's a 52 years old male patient, Caucasian. He came complaining of sudden drop of vision in the right eye. The vision is 20/50 at presentation. 2022 in the left eye. IOP is normal, clear cornea, clear lens. No medical history, and family history. Actually, his mother just developed a choroidal neovascular membrane. She's 30 years older. So this was the image as the presentation, and he had actually a previous assessment by other ophthalmologists who thought it could be a tumor. So the patient came with the initial diagnosis of either metastasis or hamartoma. And this was the CT suggested that this of the right choroid, malignant neoplasm of the right choroid. And there was no calcification, no inner thickening, and this is the B scan of this patient. Same initial diagnosis, focal bulging of the retina and posterior aspect along the right margin of the optic disc. This was the OCT that was done initially, showing sub-retinal fluid extending to the fovea. extending from the papillomacular bundle, just superior to the disc, as we can see here in the fluorescein angiography. There was no extensive leakage, late leakage, if we can say, or late hyperfluorescence. And this was the B scan of this patient. But I was actually diagnosing the patient as a choroidal neovascular membrane rather than a neoplasm. And this was the OCT angiography of this patient. And there was, as you can see here, an active lesion, subretinal, and causing this leakage and causing this subretinal fluid. So actually, after discussing this with the patient, we started giving anti-VEGF treatment, and we can see marked regression of these active choroidal neovascular membrane. And this was 1 month after, or a couple of weeks after the first injection. And this is the same, but different cut, and showing only the membrane, the subretinal fluid, and the intra-retinal fluid are much less. Even the membrane size is decreasing. So this is the last images of the same patient. This was 2 months back, and this is 1 month back. And we can see that there is marked regression of the membrane, and there is no subretinal fluid anymore. The patient was given just 2 injections till date. It was 6 months back. So at least in my hand, I think we should not rush, or we should not misdiagnose. Despite the initial diagnosis of malignancy or malignant neoplasm in this patient, everything is fine, and there is no problem whatsoever. I want to stop here first and ask you all what is your opinion about the initial diagnosis, and whether we missed anything. He's not myopic. There was no history of trauma. There was no inflammation whatsoever in this patient. So is there anything missed in this patient, or is it just an idiopathic choroidal neovascular membrane?
Ahmed, questions. This one is it's really atypical presentation for choroidal neovascular membrane. If you don't do, for example, OCT, and you just see by clinically.
Yeah, but choroidal osteoma can get complicated with choroidal neovascularization. It's well described.
Yes, I agree with you.
Before, we used to give them PDT with good response. And even today, for these choroidal osteoma that are not affecting the fovea, some people recommend the use of PDT to decalcify the edge of the choroidal osteoma in order to prevent further progression of the size of the tumor. I don't have experience treating CNV in these patients. I had a few choroidal osteomas, but thanks God they're doing fine. And I don't have experience giving PDT for choroidal osteoma either. I have given many PDTs, but not for choroidal osteoma.
So do you think it is the case of choroidal osteoma? Because I cannot see any calcification.
Yeah, it could be. I have a patient with bilateral choroidal osteoma with no calcification. I'm just waiting.
Yeah, it is reported, definitely. But,
It will be responding for the treatment, Dr. Batisha?
Yeah. The patient will be responding for the anti-VEGF, yes, because you're treating CNV, you're not treating the tumor.
But here also, even the thickness is, it's not anymore shown after the treatment, right, Ahmed?
There is still, the membrane is still there, definitely. But,
no, but can you see, a fundus? Is there any fundus?
And everything. Fundus photo recent? No.
Yeah. Okay. Is there any comment or question to Dr. Ahmed?
This is the cut here on the membrane. but no recent on this photo. Yeah, I'm sorry about that. Dr. Bishari?
Any comment from others, please?
Nothing in the choroid on OCT, at least whatever scans we are seeing. There is a shadow from overlying membrane at that fibrovascular tissue, but per se, there is nothing in the choroid like a tumor should have something in the choroid on OCT.
Yeah. So my diagnosis was only idiopathic choroidal neovascular membrane. I had actually 4 or 5 cases of idiopathic choroidal neovascular membrane. Most of them are females, actually, but without any other cause. Because if, for example, it's angioid streaks or anything else, it would not be under the label of idiopathic choroidal neovascular membrane. So, Madhav.
Yeah, thanks for the fantastic case. So I was in the opinion of looking for these, peripapillary CNVMs. Most often it is either angioid streaks in this, region, or it could be post-inflammatory.
Even myopes, sometimes myopes develop.
Myopes, yeah, degenerative myopes. Yeah, the peripapillary. So he do not have that typical angioid streaks, isn't it?
No, none. You can have a look again on the photo initially. Is totally perfect. Everything is normal. He started seeing some metamorphopsia, and there was some dots of hemorrhage around this lesion initially that totally disappeared after starting the treatment. The lesion is still there. I would not say that it is totally gone, but it is definitely much reduced in size, and there is no sub-retinal fluid, and he's dry since almost now 4 months.
Is there any inflammatory markers or clinical signs of in the peripheral retina? None. Choroidal scars?
No, none, nothing at all.
Like idiopathic to me.
Yeah. So
okay, can we proceed to the next? Dr. Ahmed.
Yes. Yeah. Okay. So the next case is a 71 years old female. She's the mother of one of my patients, a diabetic patient, but she herself, she's not diabetic. She's hypertensive for 12 years and controlled. And she developed sudden drop of vision in the left eye. The visual acuity in the right eye, 20/50, 20/400 in the left eye. She has nuclear cataract in both eyes. So this is at presentation, the OCT, full thickness macular hole with base distance of about 865 micron to be exact. So she was extremely reluctant to do any procedure or surgery. She always mentioned, I'm a 70 years old female, I don't need this to be fully corrected. But until maybe 1 month back, we just convinced her to proceed for the surgery. So as usual, a combined phaco-vitrectomy. I usually tend to do the rexes a bit smaller in these cases because when we are using the gas, not to disturb the IOL, to be fully covered by the rexes edge. I will move a bit quicker here. So here you can see the rexes is fully covering at least by 1 millimeter the edge of the one-piece IOL without any sutures, only minimal hydration of the wound. And typical vitrectomy, I usually start anterior and then core and then posterior. I use the triamcinolone to make sure and to make it easier for PVD. There was no PVD in this case. So PVD induction. then completing the vitrectomy, and then injecting dual membrane blue. I usually use the green lens for the resite to do the rexes. Here, I thought it is better to do a flap, ILM flap technique, but I usually do not tend to do just a temporal flap. I try to release all the ILM traction all around the macular hole and keep an ILM bridge over the fovea or the macular hole. So here I did the flap, and then I'm extending all around the macula to relieve any traction or from the ILM. There is many thoughts about this. Maybe just the temporal flap would be more than enough. Maybe ILM peeling, typical ILM peeling would be just enough in such case. But I'm just presenting this this case, and you can have a look on it. So extending the ILM peel. Not too much, not overdoing it, but at least wide enough to allow the retinal tissue just to relax a little bit and to cover, to close this macular hole. Then trimming the ILM just to cover the hole. And now just cleaning everything. And you can see here the flap is covering the macular hole. There was some peripheral thinning in this part, so I did laser around it. And you can see here the flap, and I made sure that it is temporarily everted on top of the fovea by drying the fovea totally. And that's the 1 day post-op. Actually, you can see the flap covering the fovea, the macular hole, very good and under gas. And actually, this patient improved to 20/30 post-op. This is another, or the last case. This is a case I did for her, actually, vitrectomy and combined vitrectomy 6 months earlier for macula off detachment. And her vision was initially in the right eye improved to 20/30, but she developed the drop of vision in the right eye. And when she came to me, I discovered that there is an epiretinal membrane and the PVR. I didn't do ILM peel in this case initially, but you can see this thick epiretinal membrane. So I used dual membrane blue dye to stain the epiretinal membrane. And it is not only the macula and extending to the periphery. So using the power gripping forceps, I peeled this epiretinal membrane and trying to extend it to the periphery. There was no detachment, some slight elevation peripheral, but that's it. And then double staining again to make sure that, and to remove the internal ILM just to prevent any recurrence of this epiretinal membrane, and trying to extend the ILM peel in this case as much as I can, so that to prevent any epiretinal membrane all over the central area, not just the fovea. Maybe you can see it at the end. Sorry, it's out of focus a little bit, but that's it. So we extended it till the far periphery, then air would be just enough. Okay. Thanks a lot.
Thank you very much, Ahmad. We can keep maybe the comment about the surgical cases because already we discussed the medical. We can have first, unless there is one, we have only 1 minute. Any comment about or question to Dr. Ahmad about the last two cases? Hole and removing the epiretinal membrane. Okay, so we can go now to Dr. Yes, Dr. Madhav. Yeah, go ahead, please.
Ashab, fantastic surgeries as usual. A nice hand. I just wanted to know about the macular hole. What was the size of macular hole in the first case?
865 micron.
Okay. So when do you, do you do just ILM peeling, or when do you do
in small holes? In this case, I did inverted flap, but in small holes, I will do ILM peeling, and that's it. Smaller than 500 or 600 micron, I will do ILM, typical ILM peel. But in larger macular holes, 800 and above, or 700 and above 600 even, I would consider flap.
Dr. Carlos Mateo said about hinging the ILM flap when you do an inverted flap superiorly and to the temporal side, so that it will not fall even when doing a fluid air exchange and putting a tamponade.
Yeah.
So I think it helps us to retain the flap in place.
Definitely.
Thank you very much. We can have now Dr. Ahmad Al-Barqi, please.
Thank you, Dr. Mohammed, for the kind invitation, and a great pleasure for me to be with my dear colleague. Today, I'm going to share a case with intraocular foreign body. I call it technique, what I call a double shake hand technique. This patient has presented to us in the emergency with the intraocular foreign body trauma while hammering. And the initial repair was done by doing a scleral wound repair, and it was a really big wound, like 7 to 8 millimeter of the sclera was done. So we have a big scleral wound. So we decided to go for intraocular foreign body removal using the 23 gauge vitrectomy, trying not to do it through the cornea, not through the sclera, not enlarging scleral wound. So we start, as you see here, with the normal, after doing the infusion, we start with phaco emulsification, and you can see some synechia from the, definitely it was inflammation and the EC was not quiet. So we do our regular phaco. In this case also, the lens was not cataractus a lot, it's a very early cataract, but in those cases, I think you need to remove the lens because for two reasons in this case, because as I told you at the beginning, I'm going to deliver it through the anterior chamber. Another issue that the site of the intraocular body was very peripheral, almost at the ciliary body. So there is no way to remove it without touching the lens. So by all means, you need to remove the lens in this case. Definitely the phaco was no problem because the patient was young, like 32 years old. The lens was soft, so we tried to remove it. It was not hard cataract or something. And also, in this case, you need to have a big rixus, and because you need a good space to remove the foreign body through it. So after doing phaco emulsification, as you can see, you need to crack or something. It was soft, so you just have a small groove, and then you rotate it with the chopper, with even the blind with the fork. No need to chopper or hard things, and then you can aspirate it. After that, the IA as usual, and then let me touch a little bit. Clean.
Ahmed, I don't know if the video is not working.
Sorry?
Properly. It's a bit slow, or it is just me.
I'm not sure. Any other comment? I stopped now the video. It's okay, Dr. Mohammed?
Yes, it's okay, Doctor. For me, it's okay.
Oh,
I think you are moving according to your. Yeah. So now
So
doing
now we are doing viscoelastic. You have to inflate the bag well. Yeah, because you need later on you need to make posterior capsulotomy. Definitely in this case, I like to suture even it's small wound 2.2 for avoiding any leakage during the vitrectomy. And later on you can decide. And so we start the vitrectomy doing the infusion. Again, as I told you, we in this case we need to inflate the bag very well because we are going to remove the posterior capsule later on. As you can see here, doing vitrectomy, detaching posterior hyaloid, and you can see the foreign body here, doing vitrectomy around the foreign body, trying to release the vitreous there, doing BVD. And if you look at the macula, you can find there is shadowing there. I think there is maybe the heat effect of the foreign body during the trauma. This is doing posterior capsulotomy. It should be a big one to avoid to relax. I mean to deliver the foreign body easily. If you look at the foreign body here, it's a big one and also irregular in shape. You can see here inside the body, it's not straight, it's curved. So I tried with my right hand to remove it, but I find myself that I hold it in a way, if I want to deliver it in this way, definitely the curve of the foreign body will touch the endothelium. So this is not a proper way to hold it. So I tried to put it back after putting some PFC there and using the chandelier for bimanual technique. Then I hold it again, and with shake hand technique, which I call it, this is the first shake hand technique now. I hold it, the foreign body, trying to hold it inside the vitreous cavity in a way that make the curve of the foreign body matching with the curve of the cornea, so the curvature. So when you deliver it, it will not touch it. But if you deliver it in opposite way, definitely it will touch the endothelium and make endothelial injury. So I'm trying now to, with the first shake hand technique, to hold it in a proper way to while delivering, to avoid touching the endothelium or the corneal endothelium. And I found in this case, it's better to hold it with the left hand, not the right hand. And then now you can see here, after that I remove the chandelier, because this is a very important point here. You have to consider, you have to control the intraocular pressure to avoid as much as you can iris prolapse during delivery of that, because I'm now going to enlarge the corneal wounds. So in this, if you have a valve technique, a valve cannula, you need to put the vent. If not, you have to control the pressure inside the eye in a way that the flow equal to outflow, the inflow equal to outflow, to avoid as much as you can prolapse of the vitreous. But it happened, but at least you have to be at least this complication. But this is the second shake hand technique with another forceps. You hold it and get it out of the cornea. Another trick here, you have to pick a very good or a very enough size corneal wound to avoid any entrapment of the foreign body during delivery. This step also should be a little bit more fast to avoid the hypotony and maybe any hemorrhage. Then putting these 3 pieces in the sulcus, centralize it, and then suture the corneal wound for sure. And if you find the hypotony, the eye is very hypotenuse, you can just turn on the infusion a little bit and turn it off again, so to avoid any continuous hypotony, avoid any hemorrhage or something like that. After complete suturing the corneal wound, we go back inside the eye, remove the PFC, and then doing peripheral vitrectomy here around the side of the tear, in the laser for sure at that area, because there is there's a tear for sure. There is a tear there, but luckily here the retina was not detached. The tear was superior. So in this case, I decided no need to do any to put silicone oil in this case, because it's a superior tear and the retina is attached. So I make it just under gas, and that's it. I think this is the end of the video. Yes, you can see here. This is the end. So the point here, if you have, and for sure I will be happy to listen to my colleagues, their opinion. Let me stop sharing first.
Thank you very much, Ahmed, for this case. Excellent handling and good videos. And this is the new technique of Dr. Ahmed Al-Barqi now. No more presentation, only videos. It's new technology.
No.
Okay, is there any questions? Because you are running behind the time. I'm sorry to say that, but it's,
Beautiful video. Sometimes what also helps is the active extrusion. So you can just apply the section with one hand and use only one forceps in case, I mean, yours was a large foreign body.
Yeah, yeah.
Not so large, so you can just bring it with the soft tip extrusion, linear pressure on the vacuum.
Exactly. But, you know, in this case specifically, yeah, I agree with you. This is another technique to hold the foreign body with the back flush needle with the active suction. But yeah, but in this case, I need to manipulate inside the eye. So I need to hold it. So if I hold it with the back flush with the other forces, I want to make it in another position, definitely it will fall down, because it's, if any touch of you remove the vacuum or the blockage, it will fall down. So, but definitely, yes, this is like another, and also very helpful in dropped IOL. Also dropped IOL because the surface, the surface is smooth and straight, not irregular, so you can easily block it or suck it with the back flush needle. Yeah.
Absolutely.
Any other comments or questions?
I think we can keep it for the end, because I'm also going to present.
Yeah. Yeah. Okay. Now we can have Dr. Yeah. Okay. Sorry, Dr. Madhav. Okay. Go ahead, Dr. Madhav.
Oh, thank you, Dr. Mohammad Al-Amri.
Thank you.
At the outset, I would like to thank for giving me an opportunity and to be amongst esteemed speakers. Well, I'm going to present medical retina as well as a surgical retinal case. The medical retina, here is a 35-year-old man presented to us with a history of floaters in the left eye since 1 year. His general health was good. There was no history of trauma, inflammation, infection, or history of exposure to radiation. His vision in the right eye, corrected vision, was 1. The left eye was not improving beyond 0.3. The pressures were normal. The anterior segment was good. On optos, or the dilated retinal evaluation, you see the right eye to be normal. The left eye showed clear vitreous cavity. You could see a telangiectatic vessels in one infratemporal quadrant with large exudation, limited till the equator. And you could also see some vitreous floaters and the epimacular membrane at macula. This was the angiographic pictures, which shows a definite leakage and capillary non-perfusion beyond the telangiectatic vessels. You can see these as these were the telangiectatic vessels, and then you have a capillary non-perfusion areas beyond that. The OCT of the right eye was essentially normal. The left eye showed a flattening of the foveal contour, hyperreflective band suggestive of epimacular membrane, intercystoid changes, and a macular thickening at 459. So I would like to discuss first what is the differential diagnosis and what's the diagnosis at this stage.
You want a comment from our colleagues?
Yes.
Okay, can we start with Dr. Vishali, please?
I don't think we can have the diagnosis. The differentials to me would be coats, adult coats, which is manifesting. I was looking for L1, but I did not see anything in the arterial knots or anything on the disc. And if you see macroaneurysms and capillary non-perfusion, but if there is vasculitis also, sarcoid will be a possibility, but I did not see vasculitis also. So to me, it will remain as probably adult coats.
There wasn't a vasculitis map. There was no vascular sheathing or vasculitis anywhere.
Yeah, that's what I said, yeah.
Okay, any other suggestion, Dr. Patricio?
You're muted, sir.
Dr. Patricio?
Yes, sorry, I was mute. I agree with Dr. Avishali. It looks like Leber's miliary aneurysms, which is a minor form of Coats disease anyhow, with typical features or look like typical features, dilated vessels. I guess that they're arteriolar vessels, I'm not sure. And then the ischemic area after the telangiectasia, yeah.
Can we go, Dr.
Yeah.
Further, Doctor?
So what will be the treatment option in cases like adult coats?
Laser.
I could go for if there is active leakage, I would go for some
Right.
anti-VEGF and laser to the ischemic areas.
Yeah.
How about treating the leakages?
Sorry, so how about treating what?
Are you planning to do a laser photocoagulation only to the ischemic areas, or as well to the leaking aneurysms?
Here we have two things. We have active exudation, that means there is active leakage, and we have an ischemia. So for active exudation, yes, I mean, you can go and try to fry the telangiectasias, but I in my hands, I'm getting good results for the few cases I have treated with anti-VEGF and laser to the ischemic area. So anti-VEGF to stop the leakage, and sometimes you get reduction in the size of the telangiectasias, and laser to the ischemic areas. And follow up, because this is a bit tricky.
Next, Doctor.
Okay, so we went, incidentally, he had a opaculated retinal break in the right eye. So we did the retinal barrage to the right eye, and we planned for the sectoral laser as advised by Dr. Patricia as well. And we planned for the intravitreal injection of anti-VEGF, ranibizumab. We did the lasers on the same day, since we waited for the pre-authorization from the insurance, and we did the injection subsequently after a week, intravitreal anti-VEGF. His vision improved to 0.7. This is how it was looking after 1.5 months. But he still had a cystoid macular edema. So we went ahead and did the second injection. And I mean, what do you do if it is a persisting cystoid macular edema after treating the telangiectatic vessels and the ischemic area with the laser? Are you planning for anything else?
Can we have Dr. Ahmad comment? Dr. Khashab?
Yes, I will either continue anti-VEGF or sometimes maybe even steroid may be helpful. But in this case, I can see from the first image that there was an epiretinal membrane. I would not rush in such case to do a vitrectomy or epiretinal membrane peeling, but it is always should be in consideration. Actually, after the comment maybe of Ahmed, I had actually one case of bilateral retinal ischemia with extensive fibrovascular proliferation. I was thinking about sickle cell in this condition, but it was cytomegalovirus, and that's what's causing this ischemia in my patient.
Okay, can we proceed, Dr.?
Yeah, so I wouldn't, I think if the time permits, I would come back and show these slides on the adult Coles disease. Let me move on to the second case.
But I have a question. How many, is there any, I mean, you will give injection one and you will see the result, or you would prefer to do a number of injection? How do you usually deal with this kind of?
We don't have a big data on adult Coles disease, though there is some case series presented by Indians. So the number of injections on an average, it's 2.7. So probably it would have been 2 to 5 injections.
Okay, so I mean, you will try, yeah. If suppose there is no edema here, suppose there is no edema or there is a mild edema and respond from the first injection, would you continue, for example, or you will just stay and just follow up and see the observation, do an observation?
No, here I thought of giving an anti-VEGF for a reason of macular edema. Otherwise, for the peripheral lesions, I've already done with the retinal laser. Okay. So if the macular edema persists, probably as we all discussed, I think I would take it up for vitrectomy and epimacular membrane peeling, because it's not going to respond to anti-VEGF. It's a taut macular membrane holding on and bringing back the macular edema.
Thank you.
The second surgical.
Like what I do, I want to the 3D, where I'm not sure whether ERM is contributing or it's just incidental. So 3D OCT gives you a very good idea whether it is actually pulling the thing or is it just lying there innocently. But your patient did respond first time to anti-VEGF. So I'm sure he will respond the second time too.
I would have shown, I showed the OCT of the second visit. In fact, it's
Still.
macular thickening is 500 more,
Okay.
500. The previous reading was 430.
And when you are doing vitrectomy, just inject Ozurdex at the end. It gives a very quick recovery. Just at the end of the surgery.
Right.
Okay,
Yeah,
we
but,
can have the second case.
Just one comment, Dr. Rahman. Yeah, as you mentioned, Dr. Rao, there is many case report is not a series because it's not that common. You use both anti-VEGF and steroid, but in this report, it was used triamcinolone, and both works actually in refractory macular edema in coated disease. So you can try, as you mentioned, anti-VEGF. If not work, you can switch to steroid.
But after how many injections you will switch?
In this report, they mentioned 3 injections. They tried 3 injections and then switch to steroids, and it worked. And also another report I've seen, it's between it starts with Avastin, and it was not working, and switched to I cannot remember Lucentis but it worked. So I mean, it's not, we don't know exactly what's going there. So it may be some kind of inflammation or just because of the laser maybe. So that's the idea. So you can try both.
Okay. So if you can, we can go to the second case, Dr. Madhav.
Yeah. So my second case is a surgical retina. He's a 42-year-old gentleman. He was referred from other hospital with a history of penetrating injury on the, they had done a initial workup, and they had also done a CT scan, which showed the metallic intraocular foreign body measuring 4.5 into 4 into 2 millimeter. And his vision was 1, and the left eye was 0.1, 0.2. What was significant about this patient was, I'll just show you the slit lamp pictures. He presented with a large subconjunctival hemorrhage on the nasal aspect. The AC was deep with a high femur. There was fibrin in the pupillary area. There was some cataractous changes in the periphery. So if you examine very closely, there was a slit-like cut on the conjunctiva, and probably that was the route of entry. And then you don't see anything beyond because of the large subconjunctival hemorrhage. On a dilated retinal evaluation, you could see there was a vitreous hemorrhage, and there was possibly a small detachment, and you couldn't identify intraocular foreign body. And you won't do a depression in such cases. Obviously, it is a globe injury, so you wouldn't do a depression. So we did the ultrasound. Again, it suggested a intraocular foreign body with a surrounding, vitreous hemorrhage and a retinal detachment. So we planned for a phaco aspiration, as Dr. Ahmad showed in the beginning. We wanted to get it through the anterior segment rather than extending the sclerotomy and bringing it out whenever it's a larger intraocular foreign body. So we thought of initially making an opening on the nasal aspect, a limited opening, conjunctival opening, and then tagging the medial rectus muscle, exploring the wound, and then suturing and going ahead with a vitrectomy to remove the intraocular foreign body. What I noticed is when I put tagging the medial rectus, I couldn't identify the entry point. Though there was some leakages seen, but I couldn't identify. It was just beneath the medial rectus. So I thought of going ahead with a vitrectomy. I pushed in a 3-gauge trocar cannula system. What I felt unusual is the eye was behaving completely abnormal, and it was becoming soft, and it was forming into a choroidals. Though the intraocular pressure was maintained at 30 or 35, there was a constant flow of fluid from the point of entry into the globe. So I decided that this is not going to happen, because I kept removing my instrument back and forth. I said, I have to increase the intraocular pressure, make sure the whole tip of the cannula is inside. It wasn't happening. So I decided, no, I have to probably go back and suture the sclera and then proceed with the vitrectomy. Again, I tried the exploring, and I found that it is not visible. This is when I decided to disinsert the medial rectus muscle. And then this is all the steps which I explained. I did multiple times, back and forth. Then I decided it's not going to happen. Then I disinserted the medial rectus muscle and then identified the route of entry exactly beneath the belly of the muscle. And then I had to suture and then came back. Since it had taken almost hour and a half in all these processes, I decided not to venture further. And then after suturing, I did like a primary wound repair, a partial vitrectomy. I left behind a little bit of LPFC and came out. This was a phacoaspiration. And then I have to come back and suture the sclera and the muscle was again reinserted and we closed the sclerotomies. After 10 days, in fact, in the post-operative period, the vision dropped to light perception. There was a severe reaction both in anterior segment and the posterior segment. This was the view. The vision was just the light perception. The pressures were also quite high. So we gave him oral steroids, antibiotics. We waited for almost 10 days. We went again after 10 days. This time, I removed the LPFC and continued vitrectomy. I noticed the intraocular foreign body has slipped from the original position. It had slided a little posteriorly because we had sutured the exit entry point, and it has stuck between the sclera and the retina. So it has slid slightly posterior. So after complete vitrectomy, I couldn't find the intraocular foreign body. So I had to I used the magnet to identify the metallic foreign body. This is a vitrectomy, continuing with a vitrectomy. I think I'll go ahead and show. This was laser done in the periphery. I think this is where I did the retinotomy after identifying with the intraocular magnet the location of intraocular foreign body. I did the retinotomy and removed the foreign body initially into the vitreous cavity and brought it to the AC. And is it moving? Yeah, this is the retinotomy. Initially diathermizing the edges so that it will not bleed. It was in between the retina and the sclera. It was stuck in the choroidal layer. Exactly like Dr. Ahmad showed, it was a handshake in a different way and brought it to the anterior chamber through the posterior capsulotomy. A superior corneal incision to accommodate the foreign body. The incision was extended. Intraocular foreign body was using the forceps. We removed the foreign body. We placed the intraocular lens and then sutured the conjunctiva, cornea, and we settled the retina and we have put the oil. I'll go to the next slide. This is how it was seen. And then subsequently, he developed again a small recurrence because of the PVR changes. We did the silicone oil removal, re-PPE, and ILM peeling, endolaser, and re-injection of silicone oil. At the end, And he has come in the last probably the month or so. He's been coming regularly. The retina is completely attached with the good chorioretinal scar, and this is how the OCT is seen. And in the last visit also, probably on 19th of October, his vision is 0.3 plus under the with oil, and the retina is stable. So the take-home message is sometimes we do see a large foreign bodies getting trapped between the layers of the eye. It can be trapped in the choroid, and that gives you a hard time.
Thank you very much, Dr. Madaf, for an excellent managing of this case. Foreign body is every time is you can find every case it will be dealt in a different way. There is no rule for how to manage the foreign body actually.
That's right.
We can have now presentation by Mr. Majid, Dr. Majid. Then we can have a discussion about the foreign body or any comment because of the time. So I don't want you to delay you more.
Okay. Hi, everyone. This is Magid Awesome from Univorts. And I'd like to thank Dr. Mohammed Al-Amri for giving me the opportunity to present tonight in front of all of you. I'd like also to thank the eminent speakers for their amazing presentations tonight. Today, mainly I'll speak about wet AMD and its management, mainly with the new medication BOVU. I'll share my screen now.
I don't understand.
Yes. So as Dr. Mohammed Al-Amri beautifully mentioned that wet AMD is the main reason or one of the main leading cause of vision loss. And actually its presence is around 10 to 20% of the total AMD patients. And for sure, fluid is the culprit of wet AMD management, as Dr. Vishali and Dr. Amri also mentioned, that the presence of the fluid is the main pathological thing here when it comes to wet AMD. And this is the main cause of the vision loss, definitely. And for sure, these are the main medications that actually were available and main treatment ways to treat wet AMD because it is a very progressive disease, as you all know. And in 2005, the anti-VEGF agents came into life, where, as you can see, these are the main trials that were conducted on the anti-VEGF therapies. And it all showed that the anti-VEGF therapy decreased the prevalence of blindness due to wet AMD. And these studies, as you can see here, for a period of 2 years. And as you know, there is still a big unmet medical need when it comes to wet AMD. First, the patient has or spend a lot of time in order to come to the clinic in order to get the injection, which is scary for him, and then traveling back. And also the caregiver also waste a lot of time when it comes to this process. Also, as you can see here, fluid remained the culprit of wet AMD, and still when it comes to the anti-VEGF treatment, there are still patients with fluids available in their retina, as you can see here in this slide. So it is mainly for sure the treatment burden is mainly the main unmet medical need when it comes to wet AMD. So now there is a new medication, a new anti-VEGF engineered for ophthalmic use, which is BOVU. As you can see here, BOVU is the smallest anti-VEGF available now in the market. Its weight is 26 kilodalton only, and it is the first single chain antibody fragment, as you can see here in this beautiful slide. This allows BOVU to be given in the pre-filled syringe by 12 molecules available to the VEGF in comparison to only 1 molecule of aflibercept in a single injection. So the binding power of BOVU is way greater when it comes to binding with the VEGF. And there are two main mega trials that were conducted on B of U, the Hook and Harrier for sure. And they are the first trials to be head-to-head for sure, double masked for sure for the patients. As you can see here, they are multi-center. Hook and Harrier were conducted in everywhere in the world, where Harrier conducted in everywhere except US. Hook included US in 408 sites, as you can see here in this beautiful slide. The primary endpoint for sure for any anti-VEGF to come into the market is to see the non-inferiority versus the available anti-VEGFs. So the primary endpoint, as you can see here, to show the non-inferiority of B of U versus aflibercept from baseline to week 48. And these two studies were conducted over a period of 2 years. As you can see here, the secondary endpoints for these two mega trials, and as you can see, the secondary main endpoints were for the percentage of patients who remained on Q12 interval directly after loading on B of U, the disease activity as state at week 16, which is very important, and I will explain later why it is very important, the CST reductions from baseline to week 16 and week 48, the probability of the patients to remain on Q12, which is the first study to show this kind of data in wet AMD management, and the reduction of the percentage of the IRF or SRF at week 16 and week 48. The inclusion criteria for these two studies were for sure the patient must provide a written informed consent, the age above 50, there is active CNV lesion after secondary to wet AMD, presence of IRF and or SRF, and also visual acuity between 78 to 23 ETDRS letters. Exclusion criteria, which is very important, the patient shouldn't have any inflammation or any infection prior to be injected with B of U. Also, the availability of fibrosis or geographical atrophy was excluded. The subretinal blood affecting foveal center or 50% or more of the lesion study eye, or any other medication available that the patient could take. So these patients were naive patients, or any history of any concurrent intraocular condition or surgical medical intervention. Here, as you can see here, the patient characteristics, they were all identical, where Hook actually included 3 arms for B of U 6 milligram, 3 milligram, and aflibercept 2 milligram. And these two studies included 1,800 patients for all of the therapy areas, as you can see. Harrier studied only B of U 6 milligram versus aflibercept 2 milligram. And what we have here in UAE is the B of U 6 milligram. As you can see here, all of the characteristics at the baseline were exactly similar. When it comes to the race, when it comes to female percentage, to the age, the visual acuity, CST, and availability of fluids as well. And this is the study design, as you can see here, where the patients were randomized to either B of U or aflibercept. They took the first 3 injections, loading phase. And then at week 16, there was a disease activity assessment. So this week 16 was head-to-head with the exact number of vials for B of U versus aflibercept. So that's why it is very important milestone here. And then the disease activity was conducted at week 20, week 32, week 44, and every 12 weeks. And aflibercept, as you can see here, was administered every 8 weeks directly after loading, while B of U, the patients were on Q12 interval directly after loading. But here, in this study, in any disease activity point, if there is still disease activity with B of U on Q12, the patient was moved to a Q8 interval, and even when stabilized, they didn't shift him back to Q12 interval. So this is very important because this is actually in the current practice, after the patient will be stabilized, for sure you will put him back on the Q12 interval. And here the week 16 disease activity assessment criteria, which is very important. As you can see, this is the criteria. The decrease in PCVA more than 5 letters compared to baseline or to week 12, or a decrease on more than 3 letters with a CST increase more than 75 micrometer compared to week 12, or the availability of new or worse IRF or IRC compared to week 12. And later on, any disease activity was mainly on the depending on the functional outcomes, the visual acuity, and the anatomical outcomes, IRF, SRF, CST, and sub-RPE. As you can see here, B of U demonstrated robust vision gains, and it was non-inferior to aflibercept, as you can see here, throughout the first year and throughout the study as well at week 96. As you can see here, B of U outperformed aflibercept with significant fewer patients with IRF or SRF at week 16 and week 48. As you can see here, significant reduction, where 7 out of 10 of the patients were free from IRF and or SRF, as you can see here in this beautiful slide. So what about the central subfield thickness reduction? Also, B of U outperformed aflibercept and when it comes to week 16, 48, and throughout the study as well, when it comes to the retinal thickness reduction. And here there was a real case in this study where, as you can see from the baseline, the retinal subfield thickness were high, 498, and visual acuity, as you can see, 65 letters, and there is fluid as well. And after 16 weeks, fluids were not there, the central subfield thickness were reduced dramatically, and the patient gained more than 15 letters. And this was not only at week 16, but also sustained throughout the study, as you can see here, with B of U. Also, what about the sub-RPE? Because as mentioned by Dr. Bishali, it is very important to also see the sub-RPE. It was reduced significantly with B of U versus aflibercept at week 16 and week 48 and 96. But what about the disease activity at week 16, which is the period where exact number of vials were given for B of U and aflibercept? As you can see here, the disease activity was reduced significantly with B of U by 30% more than aflibercept in Hook and Harrier as well. So also here, a secondary major endpoint, the proportion of patients who maintained on a Q12 interval was more than 50%, as you can see here. So which means that the majority of patients remained on Q12. And in this study also, if the patients that were moved back to Q8 and were stabilized and moved back to Q12 as the previous studies, for sure this percentage will be even higher. So what about the probability? This is the first study to show the probability of the patients who will maintain on a Q12 interval. In these two studies, the patients who managed to complete the first Q12 interval or the first 3 months interval, the probability for this patient to remain on a Q12 interval or an interval of 3 months will be more than 80% in the first year and also in the second year as well. So this means that the patient can be even treated effectively and with less number of injections, and the patient on the treatment burden for sure will be reduced for that patient, and his compliance will be better. What about the safety? As you can see here in these two studies, B of U was exhibited an overall well-tolerated safety profile in Hook and Harrier studies. However, in this point, I'd like to highlight that after the launch of B of U in USA last October 2019, B of U showed a very good efficacy when it comes to fluid control and retinal thickness reduction. However, few patients developed vasculitis. So Novartis took an action, and there was a safety review committee which was completely independent. and they studied the Hook and Harrier vasculitis cases and saw that the overall intraocular inflammation was 4%. The rate of vasculitis was 3%. The rate of the retinal vascular occlusion was 2%. And the vision loss, even with these side effects, is comparable to aflibercept, which is less than 1%. They also analyzed the patients in the real life post-marketing of Beovu. They found that these incidences or these side effects occurred in 1 injection every 1,000 injections. And also, when it comes to the vision loss, it occurred in 4 injections every 10,000 injections. So as you can see here, Beovu showed overall well-tolerated safety profile, and the benefit-risk profile of Beovu, Novartis believe in it and believes that Beovu serves the unmet medical need when it comes to wet AMD. So as you can see here, to conclude that Beovu is the only anti-VEGF to be indicated by the FDA every 3 months directly after loading, which is unique to Beovu. It comes to you in a pre-filled syringe with a mark of 0.05 milli. And also, Beovu in Hook and Harrier demonstrated robust vision gain, outperformed aflibercept with superior fluid resolution and retinal thickness reduction, maintained the majority of patients on Q12 interval throughout the week 48, exhibited an overall well-tolerated safety profile. So I'd like to thank you, and I'm welcoming any questions from your side.
Thank you, Majid, for this comprehensive and excellent presentation about the new drugs and add drugs also to management of AMD. Can you stop share, please?
Yeah, sure.
Is there any question or comments to Majid?
Dr. Majid, it's a nice presentation on brolucizumab. I need to admit that I have an initial experience of injecting brolucizumab in the last 3 or 4 months, and I found it to be very encouraging. Probably we have done around 5 to 6 patients, and one has probably finished the matched, which is 3 consecutive injections, 0, 4, and 8. Definitely it has done well. Most of them are switched patients from other anti-VEGF, and the central subthickness thickness and the best corrected visual acuity, both are wonderful. So
amazing.
We need to look at the long-term efficacy. Yeah.
Okay, Dr. Ahmad, I know that also both of you, Ahmad, Madaf, and so Barqi, Khashab, you have an experience to give this one. If there are any comment from your side or your patients?
Yeah, as Madhav mentioned, I have a couple of patients actually. They are switching from one anti-VEGF to Beovu, and both of them are very good actually in efficacy and in both efficacy and safety. So I did not face any problem. Despite that, I examined the patient after the injection and the whole periphery just to make sure that nothing is going wrong. But thank God everything is fine and the efficacy is very good. So I'm hoping that to develop more and more experience with the drug, and more patients will get benefit from the extended dosing regimen of Beovu. Thank you, Maggie, for the very nice presentation.
Yeah, I have also, I tried with one case, but it was actually a difficult case, very resistant case. So maybe I will share it later on. But the initial, I give only 1 injection, and I found actually response after 2 weeks. I see the patient 2 weeks post injection, and I find there is a very good response. And she got the second injection. So my initial impression about the efficacy, yes, it was good because this patient received a lot of injection, even laser, and no improvement. So actually, what my pain point I found about Beovu is the durability, because now, as you know, the new trend now in treating anti-VEGF or DME, the durability. That's why you need a long-acting And we are now knows about they are trying to do now the pre-filled, sorry, the BFC, the implantable device inside the eye and refill it with ranibizumab. So I mean, all the thoughts and the trends nowadays looking for some molecule that lasts longer, so it will decrease the burden for the patient and for the clinics also. So we are hoping to see in the future how it's going on, but the initial result is promising. Let's say that.
Dr. Patricio, if you have any comments.
No, I'm not muted. No.
No, I can hear you.
We still didn't start with Beovu because we need a pharmacy approval, and it's usually takes long time. But what I have read, it seems that the real world experience with Beovu is much better than the trials. So they're getting less vasculitis and less, let's say, bad outcomes and bad experiences with intravitreal injection of brolucizumab.
Okay, I have a question for you, Majid, actually. You have to comment, Dr. Vishali. I know it's India is still not launched. That's what I know.
No. It's very much launched.
Oh, okay. So if you have an experience, you can give us, please.
No, it's a good drug. It works very well. Only thing is the occlusive vasculitis is 0.5%, which kind of is a concern right now.
Okay. Do you have any experience? Do you face how many? I mean, did you use them?
Occlusive vasculitis, no.
You didn't find any?
Not yet.
For hopefully, inshallah, not. Okay, Majid, there is a question also. Whenever there is a new medication came and you are comparing, came to my mind, and maybe it came to all of us. I don't know. This is what came to my mind. Why you are comparing with aflibercept? Why you didn't compare it with ranibizumab, Lucentis?
Well, actually, for sure, both medications are very well studied and throughout the years. But maybe because the aflibercept is a newer medication, so that's why actually I believe studied Beovu versus aflibercept to show the efficacy.
I think it's more because of the aflibercept. If all agree with me or not, it's given every for example, 2 months. The Q8. That's maybe the most important reason, I think, why they are comparing with aflibercept. So what is the things make different between, I mean, okay, let's say now there is a study or there is some reports, you can say whatever it is, that aflibercept, it can be used every 12, we are hearing about every Q16. How you can make, so what is the difference if we are going to use the same medication? And also if we are going to talk only about, I mean, there will be a long duration or durability that Ahmed mentioned, Barty.
Okay, thank you so much, Dr. Amri, for this question. The point is that as per the Altair study for aflibercept, the durability was not the main point for the study. The point is that the doctors in this study treated the patient on a treat and extend basis until they reached at the end or near the end of the study to this interval. The point is that with Beovu in the Hook and Harrier, the doctor can prescribe Beovu every 3 months directly after the loading dose. Not on a treat extend.
Yes. Suppose, Majid, if we have a patient and I give 3 injections and still there is an activity, so I can go directly to Q12, or do you think I have to continue giving again another injections?
And the point is that, doctor, if you still see a disease activity after the loading dose, then you can move the patient on a Q8 interval until this patient is stabilized, and then you can move him back to the Q12 interval.
Okay, Majid, maybe this is, yeah, okay, Ahmed,
very
please.
Important point is to look for any evidence of intraocular inflammation every time you are injecting brolucizumab, and any amount of any cells in the eye you should not inject, because the predisposition of developing occlusive vasculitis is higher in the eyes who show any amount of inflammation. So,
as you know, we are knowing you. You are Dr. Dr. Ahmed Bichali. We want to get benefit from your experience. Also, you are well-known figures in uveitis. Do you have an idea why it happens? I mean, what is the reason behind having?
It is very small. It's 26 kilodaltons compared to this thing. So nobody knows why it is happening, but one of the theories is that probably it's crossing the retinal vascular endothelium. It's reaching somewhere there, and there are immune complex deposits. Whether those immune complexes are inflammatory, but now the Stanford group is saying these are anti-drug antibodies. Now that's because they have seen embolic. And this patient was fine after 2 injections, developed these embolic phenomena on 3rd injection. And, so if it is anti-drug antibodies, that makes it more complicated because that means even steroids are not going to act. So all these reports are just coming, Dr. Amri, and we are getting, but the latest is anti-drug antibodies, which causes arterial embolization.
Okay, but I don't know, Dr. Bichali, maybe Majid can give us a brief about this one because he knows
Maybe
now
it's a
more.
manufacturing thing. We don't know.
But in the maybe Doctor, I think Patricia mentioned that when it comes to the study, it shows something like that. But now there is a real life experience. It shows a report. There is thousands and thousands in the United States, in I think also in Germany, and they are showing very, very less. I mean, reporting about the vasculitis, and most probably, and most of the time, it is uveitis rather than vasculitis. I don't know if Majid can comment on that or Dr. Bichali. Yeah.
It's symbolic phenomena, what they are showing. These are just case reports. They are not this thing. But it's very good for the patients who do not have any inflammation in the eye. This is just a caution,
Okay.
If there is any inflammation, you would rather not inject this drug.
Yeah, Doctor.
I was listening to World Retina Congress last week on brolucizumab. It was an extensive talk.
Yeah,
and they were saying either it could be a type 3 hypersensitivity or a type 4 hypersensitivity.
Absolutely.
And then if it is an anti-drug antibody, why would you see a change in the first injection itself? There are cases after the first injection.
Dr. Nobody knows. These are just the postulations as yet, what could be happening. So maybe some patients are behaving differently than others. Nobody understands, because this should not be happening. We want to inject this drug to everybody because 3 months is a lot of time. So whatever it is, I'm sure Novartis is looking into it and taking care of it, whether it's a manufacturing this thing or whatever. But if you attended that Retina World Congress, you knew most of them were saying that they have stopped using it as first line already because, but it's a wonderful.
Yeah,
there is one question, Dr. Bichali. Do you remember that when we start using ILEA, even we get also to know there is endophthalmitis, and they are talking about it can be only because of the but after that we use this medication, we are not seeing, if you remember.
Yes, and of course ranibizumab remains the gold standard till today. If you ask us, we all have so much confidence in ranibizumab. And I'm sure this will become the next gold standard, but small little hiccups, if they are there, we just need to be aware of them and be more cautious in the beginning.
I like hiccups. I like this one. Very nice expression.
No, but just one comment, Dr. Muhammad, just regarding this safety issue, because I know it's a hot topic, but what I understand when I look at the data in Hook and Harrier and you look at the incidence of inflammation, it's misleading to it said IOI. We know because IOI, it's if you have a cell in the anterior chamber, it's considered as IOI. And usually we don't see our patient after ranibizumab or after Herceptin injection second day, and sometimes they might develop some cells there. So, and also another point is the incidence of this occlusive. Let's focus on the occlusive vasculitis on the real life
Yes.
or the post-marketing. If it is something related to the drug, that's the question in my mind. The incidence should be the same. If you have 1,000 patients, you did a study on 1,000 patients, and the incidence was 4%. So if you do the same drug for 100,000 patients, also the incidence should be at least comparable. But what I've seen in the real life data, the incidence is much more less than the Hawk and the Harrier. So it's something, as Dr. Juba said, it's not understood. I cannot say it's a phenomena of this one, because the incidence is that much high. We need to study more. I think Novartis, they have a lot of
They're doing it already.
and going on.
They are already started. Yeah.
Yeah. So I think, and one more thing, because you have a question about what is the difference between what's the advantage of having this drug away from the safety profile. What I understand is this drug can be injected every 12 weeks. But if you try to extend, this is a fixed dosing regimen, but if you try to extend this drug, I think you can reach much more than. So this is another advantage to my mind, that we use the aflibercept every 2 months and then extend, we reach 3 months or something like that. But if you extend a drug that is originally last for 3 months, I think in the next trial, we can reach like every 4 or 5 months, which is a good actually durability amount. So this is another advantage to my mind. When
This you can reach up to 16 weeks actually, so which is a very good interval.
Yeah.
80%.
I think we reach to the end. Thank you very much. I don't want to delay, Doctor. I tell you by 10 we will finish, but this because of Dr. Ahmed Al-Barqi. He came late.
Why?
Yeah.
Okay.
And also because what we have to we have to blame someone. There is.
I am the poor guy here. Okay.
No, you are my friend. You can accept. Anyway, thank you very much. It was a very informative and nice discussion, nice meeting. I am very happy to have all these very eminent, really eminent and friends. And I'd like to very special thanks to Victor Vishali, because all the times she never let me down. All the times whenever I call her, she's ready. And I know she is now very late in India, almost 12 o'clock. So good night for you, and have a nice weekend next. And thank you for all of you. Thanks for.
Okay.
Just before moving, I have an announcement.
Okay.
That we are going to do our quick, as you know, quick in the next year, most probably virtual, because this is what is going on in this time, and it will be from 11 to 13 of February, as you know. And so this year we'd like to invite you all participants. And I would like to mention other things. Anyone who didn't get CME certificate for the Middle East ophthalmology and he joined today, and because we are giving only for those, they attend 6 sessions according to the law that we get it from the accreditation. Anyone who joined today or the next month or the other month, we will give him the certificate of 15 CME hours. So this one is accreditation meeting. Thank you all, and good night, and see you inshallah in the next month. Thank you very much.
Thank you. Thank you. Have a good night.
Thank you.
Bye-bye.
Bye-bye.